really amazing to watch what a unified group that we have.
And so what A Twist of Fate has done is put us all together. It's allowed us to pool our data, pool our resources.
The clinic in the United States and A Twist of Fate, we can gather all this information, we can inform patients about their management, and we can provide treatment for those complications.
With the nonprofit and all the other mothers behind me, I didn't feel alone anymore.
Okay, so for the last part, I would like to talk a little bit about current management guidelines we would establish for arterial tortuosity syndrome, and also some pending research questions. And those research questions will also tell you why it is important to participate in research. So there is a gene reviews that we wrote with our team here in Ghent. Gene Reviews is actually a collection, an online book where every chapter addresses a specific disease, genetic disease, and there are guidelines for diagnosis, differential diagnosis, symptoms, and therapy that are provided for that specific disease. And so we created also one for arterial tortuosity syndrome. So actually most of what I'm going to tell is in that chapter. Of course, it was from 2014. There will be an update probably beginning next year. It will remain updated every 3 to 4 years. Because we also recently have a paper submitted to Genetics in Medicine that is likely going to be accepted, as the review was very positive. There is also some information on the poster over there. But there are some new findings that we didn't know about it before, or not that it was as frequently as we see it today in ATS. So there are some new recommendations coming from that paper as well. So I would just go over all the systems for ATS management. So first of all, I think genetics is still important at the time of diagnosis. First of all, to confirm the diagnosis, there are many other diseases that present with arterial tortuosity as well. So you need to make sure that you're looking at the right diagnosis. Nowadays, it's very easily done just by sequencing of the gene or a panel of genes you will easily find out. Second is family screening. It's an autosomal recessive disorder, as I told you. So SIPs may be at risk, or in consanguineous families there may be even nieces and nephews that might be at risk as well. Family planning is also a very important issue because there is a recurrence risk for SIPs. So for every next child that parents of an affected child, if they would have a next child, there is always a recurrence risk of 25%. So that's something they need to be aware of. And so there are different possibilities. Either you can just take the risk and see what comes. That's one possibility. But there are also nowadays two other possibilities. You can either do prenatal diagnosis, which is very early in pregnancy, around 11 weeks of pregnancy, and then we can specifically look at the mutations, whether they are present in the fetus or not. Of course, at that point, you cannot cure the disease. It's present, it's there. You know that it's present, that it's there, and then it's, of course, a decision. Do you want to terminate a pregnancy for ATS, yes or no? So that's something that we sometimes discuss if there are questions about it. Another technique would be pre-implantation genetic diagnosis, which is actually an assisted fertilization. So we take eggs from the mother, we take semen from the father, and we make actually the babies in a tube in the laboratory. And then when the embryos are growing, we can take a biopsy from the embryos. We take a few cells away, and on those cells we can see whether the embryo would have the disease or not. And then we take the embryos that don't have the mutation, so that will not have the disease later in life, and we can put them back in the womb of the mother for pregnancy. So that would be often a very good alternative for parents that would like to avoid abortion at all times. Cardiology is, of course, one of the major systems that should be followed. Clinical examinations should be routinely done, blood pressures should be measured. We know now from our larger series that there are a few children that had a very early onset and aggressive aneurysm formation of the aortic root. So that's why we now say that we should do echocardiographies every 3 months, at least until the age of 5. And if it all remains quiet afterwards, we can do this on a yearly basis. We also do a total body MRI at the time of diagnosis, and if that is normal at that point, apart from the tortuosity, then we could say we do this every 3 years. If there are specific loci where we see aneurysm formation, then we can screen more frequently. This can either be done by ultrasound measurements if possible, or by MRI if the vessel is not evaluable by ultrasound. Hyper and hypotension is something we should take in our routine observations, of course. Pneumology, as Oda said, we have several children who had severe respiratory distress at birth, so that's something we need to monitor for. And also within the first years of life, we would like to have some more aggressive treatment of lung infections. Even just viral infections may actually present more severe in ATS, so we want a quite aggressive treatment for that. Risk for emphysema is something that is present in many other connective tissue diseases. So what is emphysema? So if you look at your lung, it's all developed into smaller branches, and if you look at the end of these branches, you have like looks a bit like grapes actually. And if you would unfold all these grapes, you would have a football field large surface that is actually used to get oxygen into the body and your carbon dioxide out of the body. So what happens in emphysema is that all these grapes are going to melt together, and this causes that the surface of the lung is getting much smaller and may cause problems with oxygen and carbon dioxide flow over that lung membrane. So we know that things that may aggravate emphysema are smoking, of course, but also positive pressure ventilation. So like scuba diving, for instance, is positive pressure ventilation, so that's something we do not recommend. And also surgery that is not necessary, we actually would like to not to do that as well, because there's also positive pressure ventilation. Ocular findings, something recently from the last 2-3 years. There were some incidental reports before, but now that we have screened for this in a prospective way, we now know that it's far more frequent than we thought. So we would advise to do a yearly eye examination in every patient, and likely also in carriers, but I will come back to that. Orthopedic management, we have to monitor for bone overgrowth. As you can see, adult patients are often very tall with arterial tortuosity syndrome because the bones become much longer than in their Septs. There is a risk for scoliosis, especially until the age of 2 years old, because then there is a fast growth rate, and also during puberty when there is again, an acceleration of growth. Hernias, like diaphragmatic and sliding hernias, that's where the stomach comes through the diaphragm muscle into the thorax. It's quite often present in more than 1/3 of all patients. We've observed this, and can be treated just by standard care, but we of course need to monitor for it. Inguinal hernias, like in the groin, you can repair this by traditional surgery, but that's often not sufficient. Most of them need a mesh to kind of a cloth that is put in there just to make it more stable. Some patients do have these kinds of diverticles on the bladder, and that's something we should monitor for because it may cause infection, it may cause not emptying your bladder and so forth. So that's something we also would recommend doing a diagnosis and repeat every 3 years. Motor development, also joint problems and autonomic dysfunction. That's something where physiotherapists can help with. We know that patients with ATS often have less muscular force, especially in the beginning of life. And so that's something we can train. Also good sports are of course swimming, because then you don't have to carry your own body weight and you can strengthen your muscles. What we try to avoid is contact sports like football, basketball. Usually they're sometimes good at it because they're tall and they can jump and that's so, but it may cause injury to the joints and the ligaments. Same for competitive sports, because then if you push yourself to the limits, that's often not a good thing. Isometric exercise, like in weightlifting, is not a good idea because it raises the blood pressure enormously, and that may cause arterial complications. Fine motor skills is something we like to monitor as well. We see writing problems in children. Then for autonomic dysfunction, our autonomic nervous system is actually the nervous system that is behind our control. So I can move my arm, that's with my nervous system that I can coordinate with my brain. But then there's also a nervous system that coordinates your heart, your bowels, the vessels of your body. And sometimes we see disturbances in that nervous system. And sometimes the people, when they get up from their chair, they feel dizzy for a certain time. Sometimes they have more frequent or less frequent stools. That's also something that may be related to that. So for those that have experienced a lot of dizziness, we might need to monitor for hypotension when they get up. And there are some specific exercises you can do, and also sometimes with adding a little bit of salt to the diet, or in case of hypertension, of course, you have to remove the salt from the diet. So that's something that might be individually different. And of course, exercise is also something that may improve these symptoms. Often patients may have problems with cold fingers, cold hands. It's important to have warm clothing during the winter, but not just the clothes, but also gloves, something on the head that keeps everything warm. Because sometimes just having a cool wind on the head may already cause the fingers to be cold and with a strange feeling to it. So that's for management. Of course, you can all have the slides afterwards. Some pending research questions, because there are a few things we didn't touch yet in detail today. So one of the first things we want to know is there a phenotype in carriers? We have several incidences of patients having aneurysms of the aortic root being a carrier of one mutation in the SLC2E10 gene. So what we did at previous conferences, we also took biopsies of carriers. And so what you see here again is the elastic fiber like Oda already showed. So this is actually a normal elastic fiber, and these are elastic fibers from 3 carriers. And so you can see at the edges that the elastic fibers are not as smooth as in the control. So it seems that there is still a minor abnormality of the elastic fiber in carriers. Well, this one looks almost normal, but still you can see the...
Just ask for the collagen.
For the collagen?
Diameter is different.
Yeah, well, something we might not need to do is quantify the diameter, because just looking by it with the eye, there seems to be some variability in the diameter, but we need to quantify it to be sure. So what we also observed is when we screened carriers with echocardiography, we measure the width of the aortic root. And so we found that one patient had a rather broad aortic root. Also, we had 7 incidental cases of patients who had aortic root dilatation or dissection, who actually have been screened for a connective tissue gene panel, and the only thing that came out was one mutation in SLC2A10 gene. So that's something that caught our attention. And so what we did is we had a few conformational cohorts. So we also screened a large cohort of patients with aortic root aneurysms, both from Ghent and both from Houston, Texas, and from Antwerp. And we found out that there were more mutations present in those cohorts than in the control population. And this seems quite significant, but we are still working on further detailed statistics. So what about the elastic fiber? What are actually these elastic fibers we are talking about? Well, elastic fiber, you can compare it like a building under construction, where you see these rod-like structures in the center that are wrapped around with concrete. Except the elastin fiber is not very hard, but it's more resilient. But that's a bit the same buildup. You get microfibrils that make up these rods, and then the concrete is the elastin that is wrapped around it. And there are many diseases that cause elastic fiber defects, and if that's present from birth, then we consider this a genetic elastic fiber disease, like many forms of cutis laxa. If we see this later in life, and this happens at a normal rate also during aging, then this results from destruction of elastic fibers. And so normal aging, like in elder people, or emphysema or aortic dilatation, are diseases that are quite frequently seen in the population. And so also understanding the basics in ATS and in cutis laxa of what is actually going wrong in these diseases might also help us to find cures for the more common forms of these diseases in the population. So, but why is it that there are elastic fiber abnormalities? So there are still a few things we want to solve. First of all, the localization. Anne-Catherine has already told us about that we now have our techniques ready and can look at the localization, which is likely to be in the endoplasmatic reticulum and the mitochondria. And at the substrate, that we have more and more arguments that it's not glucose that it was initially thought to transport, but rather to be vitamin C. And so this is a very complicated scheme of a cell where we have all kinds of elastic fiber defects upon it, all genetic defects that lead to the started elastic fiber formation in cutis laxa. But also the gluten is also somewhere over there in the Golgi apparatus, in the ER, in the mitochondria. So I won't go into detail in that, but it's also by interconnecting all these diseases that we can find links and common disturbances in cellular pathways that may help us to understand these diseases. So vitamin C, why would it actually cause elastic fiber and perhaps also collagen problems? Well, vitamin C is important to link all these elastin and collagen molecules together. So collagen is a bit like a rope-like structure, and a rope, if you pull it apart, you get all these very tiny threads. It has to be linked together somehow, and that's the same in our bodies. It has to become one firm rope, and that's what vitamin C is important for. It is actually a linking molecule, or actually a molecule that is needed to link these rope-like structures together. Also in the mitochondria, and the mitochondria are actually our energy fabrics in our cells of all our body. So we eat, and we eat sugars. We make sugars in our body from all what we eat. We also have oxygen, and these mitochondria use the sugar and the oxygen to make chemical energy that can be used for other processes. But during that reaction to make energy molecules, there are some side products, and we call that ROS, reactive oxygen species. These are actually molecules that may cause damage to your cells. And so these need to be removed quickly from your cells and from the body. And also, vitamin C is one of the molecules that is important to scavenge these toxic molecules away. So that might be another mechanism that might be involved. So I won't go into detail in that, but we are together with a group of Rotterdam University. We are also looking at migration, proliferation of cells and cell phenotypes, how they behave. Another thing is some cells may actually change their behavior upon environmental circumstances. For instance, fibroblasts, which are just the regular connective tissue cells, they may appear in a different shape and may become myofibroblasts or even smooth muscle cells if you just give them another environment, other growth factors around. And so what we also may observe, but we are still confirming these data, is that under normal circumstances, you only will see that behavior that a fibroblast will form a smooth muscle cell or a vessel cell only under treatment with growth factors. While in ATS, it seems that these transformation already occurs without adding these growth factors. So that is something we are looking into. I won't go to further detail on all the research, that might be complicated, but I'm happy to talk about that. It's important that for you can also make your contribution to research. First of all, by centralizing the clinical data through the registry. Also by biobanking of tissue. So what we often request is a small piece of skin. We can look at with the electron microscopy in very high detail. We can also culture the cells, use these cells to look at the mechanisms of the disease in human samples. That combined with the animal modeling, what we see in animals, we can see if it's also present in humans. So it may all interconnect at a later stage. And also, I think participating in research, if you have a rare disorder, may also be helpful in giving some positive feelings about the disease. If you can help the community, if you can help other patients with it, I think that is very valuable as well. So that's actually what I would like to end with. And so if there are questions, you can always ask us. We can also talk about it further during dinner. I also saw that Paul arrived. So Paul is one of the co-investigators on the ATS projects. He's also he was actually the first author on the paper of the gene discovery. So we are glad that he's here as well, and you can ask him questions as well.
I did have a question.
Yep.
So, you know, when we did all the echoes, the first set, there was some carriers that you had some concerns about, and you talked about not doing weightlifting. What about carriers doing weightlifting? Do you suggest until we've been all scanned that you don't want to?
About weightlifting, as long as the aorta is not broad yet, if you're still within normal limits, I don't think there is a major problem doing some muscular things. But if your aorta would be at the upper limits, then I would advise to do that anymore. But I think for now, I don't think we can say that all carriers cannot do any weightlifting things. Yeah, that's a little bit too early to state that. But I would recommend to follow up for carriers as well. And once you see that there is a progressive dilation of the aorta, then I would advise not to do the weightlifting anymore.
Yeah, thanks.
I have a question.
Mm-hmm.
So, why some patients are having the symptoms very bad and others might have very mild or no complications?
Well, we are aware of that variability, and we see it in many diseases, in many genetic diseases, also in other related diseases like Lewis-Dietz syndrome or Marfan syndrome. And we actually do not understand at this point why it is. Just from a point of view from the mutations in the gene, we actually find the same mutations sometimes in patients with a severe phenotype and patients with a very mild phenotype. So what is making the difference? Is it the other genetic background? Are there any environmental factors? We don't know at this point, and that will be research for the next 10 to 20 years, I guess. It wasn't very frequent. We actually had 6 patients, I think, out of the 50 that had an important dilation at a young age and had surgery for that. So it's 12%. So I wouldn't take the 12% if I had a chance and
Because
could prevent it.
we have a patient in the U.S. too that is, the child is very young and has progressed pretty quickly. So it's just not worth chancing. It's just easier to do the hassle and go and get it just to make sure.
The other thing, symptoms with carriers, you did mention the elastic skin because I've noticed on my other kids that their skin is a bit elastic as well.
It's possible.
What about other symptoms like the sunken chest? I have a nephew with a sunken chest, so I don't know whether yours is likely to go and check.
Well, at this point, now we're still looking mainly at a cardiovascular phenotype in first instance and see if we can show that there is a cardiovascular risk in carriers. But then in the next step we need to follow carriers prospectively and see is there indeed more overgrowth, like sunken chest is because the ribs are too long and so the chest flops in a little bit. So that's something we need to follow prospectively once we have sufficient carriers that will give their clinical data to research. Yeah.
And I know that we're pushing the registry. I hope you don't mind me saying, but going back to why some of the kids have more obvious issues than others, like Aiden, you could tell if you knew what like all the characteristics that he has ATS, but he is pretty normal other than cardiac wise. So that's one thing the registry is going to do is we'll be able, when you put your genetic information in there, we'll be able to start comparing and noticing like what genes have certain specific issues more so than others.
Thank you very much. Really doing a big job. You and your staff and Andrea as well. Thank you.
Thank you.
Thank you. So once again, I would like to thank you all, and also especially Oran, Katrien, and Andrea for giving.